And we have known that forever, yeah? I mean, all publications going back to the 1960s and 1970s recognize that lentigo maligna is a relatively slow-growing process, does not necessarily evolve into invasive and deadly disease. And in fact, in the early days, and you'll see in a moment, it wasn't even called melanoma, okay? So with that being the lowest hanging of fruit possible, even in the realm of melanoma in situ, my talk is geared towards the shifting paradigms in lentigo maligna. I'm going to present a bunch of stuff that will be new and will be controversial, but just go through it, process what people are starting to say. My disclosures here, but for the purposes of this talk, I hope you don't see that there are any conflicts. So the first thing is definition. So what is lentigo maligna? And I want to go back to the NCI definition. And if you notice, the NCI definition is listed right here. It consists of abnormal melanocytes confined to the epidermis. These abnormal melanocytes may become cancer. The NCI does not consider melanoma in situ to be a cancer, which is amazing, right? Because all of us think of it as cancer. So a little bit of historical perspective, that how is it that we got to this point where our belief system is anchored on the fact that melanoma in situ is actually a cancer. And so a little historical perspective. So up until 1985, this entity was called Hutchinson freckle. And if you look at the textbooks, I mean, this is just an image taken from a textbook, that obviously is lentigo maligna. Yeah, we all identify that as a lentigo maligna. It's covering at least a third of the cheek of this person. And yet, it was not categorized as a cancer. It was categorized as an obligate precursor to a malignancy, okay? But something occurred, a shift occurred around 1985 that transformed the way dermatologists viewed the Hutchinson freckle. And that occurred with an editorial. In 1985, Dr. Ackerman had an editorial that no one should die of malignant melanoma. And in this editorial, he made the point that melanoma in situ is the earliest form of melanoma, and went on to say that if we in the world, or in the United States, let's take the US for a moment, could eradicate melanoma in situ, that we would then end the epidemic of melanoma and no one will die from it. And in the editorial, he went on to say that dermatologists should be trained to find it, podiatrists, massage therapists, your hairdresser, everyone that looks at skin should be taught how to identify melanoma in situ, because it's only by eradicating melanoma in situ that we'll end death from melanoma. And basically convinced the entire dermatology world that melanoma in situ, if you leave it alone, the person will die. And we kind of accepted it, yeah, as truth. And then, shortly after that editorial, other things occurred. And I'm going to kind of give you the timeline back to that graph that I showed you initially. So if you can see Ackerman's editorial, and shortly thereafter comes in the dermatoscope, okay? So now we are magnifying everything that we are seeing. And in essence, we're kind of amplifying the problem, aren't we? And then along comes the polarized dermatoscope. And that made it even easier to use dermoscopy. Well, we continue to amplify the problem. And then comes in confocal microscopy. I mean, it just goes on and on. So in essence, we are so focused on finding this disease, this entity, whatever it is, that it has kind of spiraled out of control in finding melanoma in situ. And to some extent, that led to the editorial, which when I first saw it in the New England Journal, I had a kind of visceral reaction that the 40 years of my career were in vain. But I think that there's a lot of truth that is being said here. And I think it took a few years for me to even process and understand exactly what was being said. And I think I mean, the heightened awareness and this whole feedback loop, it's affecting the population, right? How the population views this, how we, the dermatologists, are viewing it, how dermatopathologists view it. And obviously that all goes back to what the primary care physicians view it as well. So it is this kind of vicious cycle that is just perpetuating this problem. But I want to go back and kind of just have you appreciate that, you know, the umbrella of melanoma, we know has many different subtypes. I mean, the clearest, let's take lentigo maligna, yeah, and nodular melanoma. Clearly different biologies, right? One that's there for a couple of months and can become thick. One is there for decades and is still at most in situ microinvasive. So we know that there are biological differences. And so there are fast-growing melanomas, there are sort of intermediate growth melanomas, there are very slow-growing melanomas, and then there may be some melanomas that don't progress, or in fact, even involute, right? And so we're gonna talk a little bit about all of those. There is this article that I'll refer you to, where they estimated that we are currently, when you look at just melanoma in situ, that about 85 to 90% of the melanoma in situs that we are diagnosing are overdiagnosed. That is pretty impressive, right? That it's that much. In terms of etiology, we know that there are differences when it comes to lentiginous melanoma and superficial spreading type melanoma. So lentiginous melanoma is heavily driven by UV exposure, UV mutations, as opposed to the nevus phenotype, right? That's driving at least the superficial spreading types. And that also is seen when you look at the mutation burden in these tumors and the UV signature mutations that, and even in melanoma in situ of the lentiginous type, they have a much higher mutation burden than the superficial spreading type, and many more mutations that are related to chronic UV exposure. So that is sort of the textbook description of lentigo maligna and its sort of different divergent pathways. But I'm going to introduce another thought that has been percolating around the European community, and that is the question whether lentigo maligna is even one disease, or maybe it has in itself two different processes. And just take a look at the images that are shown here on the left-hand side. Relatively confined, isolated lesion, no skip areas, compared to one that is more irregular, diffuse skip areas, and the ones that have the skip areas also have more UV damage, right? The ones that are isolated have a little less UV damage. And so there is a proposal that perhaps there are two different types, and in fact that these two types will also respond differently to treatments, which I'll talk about in a moment. And then so the chronic sun damage one with the field cancerization is leading to that classic lentiginous melanoma with the ill-defined borders. And then there's one that has less actinic damage and has well-defined borders as shown on the right-hand side. So these investigators went ahead and looked at the distribution of these two different types of lentigo maligna, and they found that in women, it tends to be more on the cheeks, so a little bit lateral to the nose, whereas men, it tends to be more centrofacial. And and that's sort of highlighted in these two cases. So on the women, a little bit away from the nose, and in males, it's much more towards the center of the face. And then they went ahead and they said, what disease entity actually goes along that same distribution pattern? And they said rosacea. So that the question arises is, can chronic inflammation be a driver of melanoma? And we know from work now that's occurred on melanomas on acral skin, so acral lentiginous type, that perhaps friction and trauma may be a contributor to the melanomagenesis, and in a similar fashion whether rosacea can be. And long behold, they did find a pretty significant odds ratio association of lentigo maligna with rosacea. And then they went ahead and they made a proposal, and again, it's just a hypothesis, that perhaps the pro-inflammatory cytokines together with UV exposure may be driving the process of lentigo maligna, at least one subtype of lentigo maligna. Time will tell, but it's food for thought. In terms of epidemiology, I think we know a lot, but I want to focus on one issue, and that's at the bottom. That today it's still considered a disease of the elderly. But as we have become better and better at identifying lentigo maligna, and we're using technology to make that even better, right, if we want to say better, that idea that it's a disease of the elderly is actually not true. This is a paper that I'll refer you to, and they're saying that if you look at lentigo maligna, the earliest time point where you see it is somewhere between 30 and 40 or 45 years of age. And when you find them at that age, they tend to be small, okay? Dermoscopically, they still have the features of lentigo maligna, but clinically, they look just like a lentigo. And that was shown that not only are they smaller, they have fewer dermoscopic features, but they do have the dermoscopic features that helps you to recognize them as lentigo maligna. So in fact, the first origin of lentigo maligna is probably somewhere around, say, 40, right? And then by the time we recognize it, bless you, that's when it's sort of this, encompassing a fourth of the face or, a significant portion of the cheek. In terms of morphology, again, we have the two different types. The one that is the isolated, well-defined lesion, those are easy, right? We don't need anything to help. In the more lentiginous that have the skip areas, in those, Wood's light examination is really helpful in delineating the borders, and that's just highlighted in the image at the bottom of a patient of mine that I saw a few months ago, where you can see a lentiginous macule. It's not really that well defined, but with Wood's light examination, it really helps you to know where the border of that lentigo maligna is. Now, that's on the clinical side, but we know all the issues with clinical exam and that it can be challenging. And it's now where dermoscopy came in. So, and in fact, it was a game changer in helping us to diagnose lentigo maligna at an earlier and earlier time, in essence being smaller and smaller. We hypothesized, not we, but the general world of dermatology, that the stem cell probably has something to do with melanoma origin, or at least the environment where the stem cell is residing has something to do with how melanoma grows. And to no surprise, the stem cell on the face resides in the hair bulge. And in early lentigo maligna, everything is folliculocentric. All of the features that you see on dermoscopy are folliculocentric. That kind of supports this idea that there's something unique about the follicle where the melanoma preferentially grows early in its evolution. And that's highlighted also in this editorial in the 3 roots of melanoma. And in this folliculocentric process, these are all the features that people know in dermoscopy: perifollicular granularity, asymmetric follicular openings, perifollicular radial projection, circle within circle. It's all folliculocentric. As the melanoma progresses, it creates the angulated lines, it causes obliteration of follicles, et cetera, but by then it's not so difficult to find these melanomas. And that's exemplified here on the left-hand side as a 6 millimeter lentigo maligna that has features of circle, and within the circle asymmetric follicular openings, but subtle, they're subtle. On the right-hand side is completely blatant melanoma in situ with all of the features from angulated lines to perifollicular changes, et cetera. So we have been able to recognize lentigo maligna smaller, and in fact, this was just a poster that we presented, but now there's a paper coming out where we have a series of about, I forget, like 60 melanoma in situ lentigo maligna type on the face that are less than a centimeter in diameter. So bona fide, these are not AIMP, these are melanoma, or the so-called lentiginous melanoma. So we have the ability to find them at an earlier stage. Enter confocal microscopy. It becomes even more powerful in terms of finding it earlier, because we can see perifollicular changes dendritic cells, nucleated cells. And in fact, if you have pagetoid infiltration, atypical round cells, and dendritic cells, that the probability of melanoma in such a lesion is 98%. So really, really good. And in fact, the world record for the smallest melanoma ever found is now official, and it's less than 1 millimeter, okay? 0.65 millimeters, found with confocal microscopy with these dendritic cells. But now I question, have we just gone absolutely loony here, right? That we are going to this level? I even question whether the paper on the 1 centimeter, less than 1 centimeter, is taking this a little bit far, right? Again, it's food for thought for now. But with that said, I mean, we do have to talk a little bit about prognosis. We know that despite lentigo maligna being there for a very, very long time, that there are some individuals that will develop microinvasive disease, and there are some that will develop metastatic disease. It does happen, okay? And I'll highlight that with this patient here, has this lentiginous macule. You can see on Wood's light examination, you can see the borders much better. And if we look at one area, the sort of the more lentiginous lighter tan area, it has all of the features of lentigo maligna melanoma in situ with the perifollicular changes, circle within circle, granularity, asymmetric follicular openings, and those are highlighted here. So it has features of lentigo maligna, no problem. But as you scan this lesion, there is another spot, and by the way, this area that was biopsied did show a melanoma in situ, lentigo maligna type. But as you evaluate this lesion, there is an area that appears different. And so here what you see is a bluish color. What is blue? Tyndall effect, melanin deep in the dermis. So blue is a color that should make you think invasion. 2, it has shiny white structures, stromal alteration, another feature that suggests invasion. And number 3, it has tiny little blood vessels, which is neoangiogenesis. So 3 separate features suggestive of invasion. And so a directed punch biopsy at that area was performed and revealed a 1.3 millimeter melanoma, lentiginous melanoma, arising within this larger lentigo. So it does happen, right? But rare. So the question arises, well, what do we know about the rate of progression? Up until recently, the only paper that we had was this one from Marty Weinstock and Art Sober that showed that the lifetime risk for developing invasive melanoma in a lentigo maligna was about 5%. Right? That's about and that's what the number we've used pretty much up until this paper. And this came out of the Australian work from Scott Menzies and Pascal Guitarra. And what they showed is that the rate of progression is about 3.5% per year. That's the risk, 3.5% per year. And the average latency period is 28 years from in situ to invasive disease. But the important thing that they highlighted in their discussion, I also highlighted in black here, underlined in black, that they kind of said that instead of a constant risk per annum of all lentigo maligna progressing to lentigo maligna, it's only a subset that do that. And that our task is to try and identify which subset is the one that needs respect and which is the subset that we can be a little bit more relaxed about, yeah? So there's obviously a call for action, right? We need to understand whether lentigo maligna is one disease. Is it a cancer to begin with? Are there multiple pathways? Do all of them need to be treated in the same manner? Are there going to be improved ways to prognosticate which ones will be the ones to be concerned about? And obviously, we need better studies on how do we manage them. So it's basically controlled trials, right? Randomized controlled trials. And up until recently, and I'll share that one trial with you, we have nothing. We have the first one just recently got published. So a lot still has to be done. In terms of predicting which melanomas will be aggressive versus not aggressive, there are people that are working on it. Obviously, I'm talking about on the in vivo level, not once it's been cut out. And so this is just one example of, there are many, of looking at morphologic criteria, whether it's based on dermoscopy or confocal microscopy, to try and help tease apart which are the melanomas of concern and which are not. However, while we await these results, obviously we're kind of stuck, right? So if you know it's a melanoma, yeah, or a concept of melanoma, you have to do something. You can't just say, go home, you got nothing. Whether it's active surveillance or whatever intervention we'll talk about, but something has to happen to address it. On the academic level, obviously, we need to address all the questions that I arose. I hope, I don't know if it'll happen, I hope that within my career, what's left of it, that we'll have some kind of a grading system, as we have in prostate cancer with Gleason scoring. Not every man with prostate cancer needs to get their prostate yanked out, right? They have broad perspective, and enough so that the patients are comfortable with it and the general oncology world is comfortable with it. And I think that that's going to be our goal, is to try and find out what are the features, what are the criteria, and maybe a combination of criteria that can help us to kind of tease apart which are the indolent and which are the not, and which are the ones that require respect. In terms of management, for now, it is, well, always it should be a shared decision-making process, and we have whatever information we have at our disposal, we need to utilize it and discuss it with the patients and have the patients come to a place that they're comfortable with in terms of management, yeah? And so the first one that I'm going to start off with is, don't just do something. It's okay to stand there, yeah? And active surveillance is not a problem. I mean, active surveillance is being done for lots of cancers: indolent lymphoma, prostate cancer, papillary thyroid cancer. I mean, it's okay to sometimes just stand there, as long as the patient and you are comfortable with that idea. Obviously, you have to discuss with them all of the issues: the annual risk, the lifetime risk, the latency period, the things we know, the things we don't know. And after this thorough discussion, right, the two of you come up to some kind of a reasonable approach to this entity. I come back to this graph on the slow-growing and fast-growing melanoma issue. Lentigo maligna, for my career, which has now spanned about 35 years, slow-growing. I'm comfortable with this notion. And many of my patients now are comfortable with it as well. And so I have about 15 patients now with proven lentigo maligna who have, after this discussion, have elected not to do anything. So here's this lady. She's now 93 years old, okay? In 2017, I already identified the lentigo maligna. She wanted nothing done after hearing what I had to say about lentigo maligna. We see her every 6 months. It has indeed gotten bigger, as you can see here. There are no features of invasive disease, and she is completely at ease with continuing to monitor. So every 6 months I see her, yeah? And I have another 14 patients exactly like this. So active surveillance is okay in such a scenario. Can lentigo maligna involute? We now have 3 patients where biopsy-proven lentigo maligna disappeared. How the heck is that possible? Here is a patient of mine, an ophthalmologist. Lentigo maligna on the nasal tip. He said, "Doc, no way are you getting rid of this and putting a forehead flap on my nose. I'd rather die." I said, "I'm totally fine with that. We'll follow it." Look at this. It's completely gone. Where'd it go? And 2 other patients, exactly same scenario. So lentigo maligna has the ability to also involute. Now, in terms of having to do something, what are the things that we have at our disposal? We have surgery, radiation, and Micromod, 3 things. So here is a 90-year-old lady with half of her cheek, if not more, covered with lentigo maligna. What are you going to recommend, and why? Okay. So surgery, which we consider the gold standard, we need to know that this is pretty significant, right? Especially if it's a lesion that big. And so the larger the lesion, the larger the margins have to be before you get clearance, which means surgically, she will lose probably most of her cheek, right? So a pretty morbid procedure for a 90-plus-year-old lady who, I don't know, maybe has another 8 years or so to live. So just be aware that when you're doing surgery, what are you directing your patient towards? So, of course, it can be done. Sure, we have plastic surgeons that can do miracles in terms of repair, but is it really necessary is really the question that's at hand. In terms of the very small, early lentigo maligna, you can convince me that maybe, if it's at this early stage, maybe it's okay to cut it out, right? Because the procedure itself, relatively simple, and you could do that. But for the majority of lentigo maligna that we are diagnosing today, I think I question, and at least in the last few years, I have not directed any of my patients towards surgery for those. Radiation therapy is the second one. It got a bad kind of reputation. And it got a bad reputation by a project that came out in the 1970s and 80s out of NYU, where they said that the recurrence rate was really high, like 25%, and that you just can't accept the 25% recurrence rate, but they didn't take into account were patients dying, right? The real crux of the issue. Since then, there have been lots of studies on the radiation front that it works quite well. I mean, the recurrence rates for local recurrence are somewhere between 7 and 10%. Not as bad as they were reported in 1976. So radiation is an option. So don't forget, and we'll get back to that in a second. And then there's imiquimod. Yeah? So we know it's a toll-like receptor. We know what it does. It induces the immune system, recognize these cells, and kind of destroys the cells. And the track record for imiquimod is also quite good if you look at mortality as your endpoint. So if you look at in this review of the studies, that your recurrence rate at 3 years, as you can see here, is about 12 or 13%, and then by 10 years it's 25%. So you say, oh my God, that's horrible, 25% 10-year recurrence rate. But notice no death, not a single one. Yeah? So if mortality is your endpoint, there was nothing bad actually happened to these patients, right? And in fact, 75% of them did fine without any recurrence. So keep that in mind, right? And then since then, there are other studies. So this one here that came out in the Blue Journal showing recurrence rate as low as 2.3%, and then another one in the British Journal, the 95% cure rates at 3 years with imiquimod. Okay, so in that patient that I just showed you, who was 90 years old, the part that I didn't tell you is that she was still working. She had a handicapped child who was at this point, an adult that she was taking care of. She was cleaning toilets to support herself and her kid. How the heck were you going to take her cheek off? It's impossible. You can't do that. She says, Doc, I can't. I have to keep working. So we put her on imiquimod. And look at the beautiful response. Yeah? I mean, by the time that she came back at the 12-month visit, the skin of the treated side looked younger and healthier than the other side. Yeah? And then I highlight that here is look at the Woods light pre-treatment and the Woods light after treatment. Her lentigines went away. Yeah? I mean, and then 9 years later, she passed away from natural causes. Never interrupted her work, yeah, in all those years. Remarkable lady. So know that there are other options other than cutting. And then the breaking news, which actually is not breaking news anymore, is this paper that came out in the Blue Journal as well, which is the first and only randomized trial that compared radiation to imiquimod and looking at the long-term outcomes. And basically what they found is that imiquimod radiation equivalent. okay? And it wasn't, I mean, for a whole host of reasons, they didn't have long enough follow-up time and not enough patients. Part of it had to do with COVID, that the graft didn't split far enough apart to become significant, but there is a pretty significant signal that the imiquimod is actually better than radiation, okay? And that partly has to do, that many surmise, is that since lentigo maligna has a very high mutation burden, that the imiquimod is working because of this high mutation burden. And now we come back to what I started with. It also explains why the isolated lentigo maligna that is occurring on non-sun damaged skin tend not to respond to imiquimod, yeah? And so we may have clues as to who will respond and who won't if we start to subtype lentigo malignas. And in fact, besides the clinical and dermoscopy side of that, there are now also genes that are being looked at that can help kind of separate out those that will respond to imiquimod and those that will not. And I just refer you to the paper for you to sort of read that. But you can see all the different avenues that people are starting to take to address not only risk of progression, but also response to treatment for lentigo maligna. And here is a very recent patient of mine, and she has a biopsy-proven lentigo maligna, again, very similar to the ophthalmologist patient of mine, on the nasal tip. And after a thorough discussion, she also decided that she'll treat it with imiquimod, and I'll just give you, she allowed me to show these images of the response at 3 months of imiquimod treatment. It's 2 years later, okay? I don't know of any treatment that could do a better job than this, which is a completely normal nose. Actually, I don't even see the biopsy scar. I mean, if I look close enough, I'll probably find it. But I mean, it's pretty remarkable and has become sort of my main go-to, kind of telling patients to, channeling that way. But we'll have more debate also during the Q&A. So all of the answers, but waiting for us while we poor folks ask questions and wait for the secrets of God to open themselves up to us, when they all the while are waiting for us to open ourselves up to them. And with that, I want to thank you. I also want to leave you with another kind of plug that we do have a dermoscopy, 3-day dermoscopy session for those of you who like dermoscopy. We have it always in a national park. This time it'll be at the New River Gorge National Park. So now, Atta Mushiri is going to come up, and we're going to and he's going to tell us a little bit about the path end of this problem. And let me see if I can get. Will you be bringing up the talk, or do I have to do that? I have to do that. Okay. There it is.
Thank you so much. Not fall all over. All right. Hi, everyone. My name is Atta Mushiri. I am a dermatologist, dermatopathologist at NYU, and I see a few familiar faces from the controversies session earlier today, and so some of the slides here are gonna feel kind of familiar, but I'm really honored to follow that awesome presentation and to also put forward the idea that it might be time for us to take one of the M's out of MMIS. And as part of that, how it is that the empath system, which we'll talk about shortly, has been guiding us towards that reality for pretty much the last 12 years. So I have no relevant financial disclosures. I'm definitely going to say some controversial things that will make people a little uncomfortable, and that's probably a good thing on balance. Okay, so I want to start my time off by introducing you to one of my patients, the way that I don't have 15 of them that are like this, but I have at least one that was very, very memorable. And she was a 60-year-old, was 60 at the time, 60-year-old woman from India who was referred to me primarily for management of basal cell carcinomas on her face. And the context, if you may have guessed, is that she has xeroderma pigmentosum. And she's lived with skin cancers basically her whole life. Interestingly, had never had a full skin exam prior to coming to me, which is really, really interesting. But these lesions, when she was growing up in, and I'm talking about the basal cells, when she was growing up in India, were very bothersome to her. From time to time, they would bleed, and they were always sort of like conservatively, destructively managed for her, and she kind of just went along her way. Now, she'd seen a community dermatologist in the Seattle area who had biopsied a few of these basal cells and really wanted her kind of in the academic wheelhouse, and we had discussed, oh, she might be a good candidate for me to try vismodegib for her, for example, just to, not have to mangle her face. You can see that she has some basal cells in her right nasolabial fold, these large plaques that were, bothersome and bleeding from time to time. So when I met her at first, she came in and she had this beautiful makeup on. So I had no sense of what was going on with her forehead. And we got about 3/4 of the way through the visit, and her daughter, who had accompanied her, kind of pulled me aside as her mom went out to the bathroom. And she said, "Can you please ask my mom to take her makeup off?" And I'm like, "Why?" And she said, "You'll understand." Okay. So, she came back, was, getting into the gown. And I said, "Do you mind taking off the makeup, on your forehead?" And she immediately got very defensive. "Why do you want me to take that?" It seems like it might be covering some pigmentation. It's probably important for my exam to see that area. So she, I left, came out of the room, came back in, see this, and oh my God, that's jarring, right? So pretty obvious, at least melanoma in situ on her forehead. There's a huge patch of regression off to the left side of it, and it's creeping down onto the left side of her nasal bridge. Now, that got my attention. I was, it's like hard not to stare at it, kind of like a train wreck. You're just like rubbernecking the whole time, like catches your eye. The interesting thing is she had 4 melanomas, invasive melanomas, that I found on her, 2 on each of her arms, 1 on her back and 1 on her thigh, all of which were PT4A deep lesions. All right, these are bad, bad melanomas. And this guy, I managed to convince her to let me do a couple prosciutto slices off of her forehead to just establish the diagnosis and make sure we're not missing anything obviously invasive, because she had bigger fish to fry. And I'm gonna sort of put her on the back burner. So when I think of melanoma in situ and how crazy it can get, this is the most outlandish I've seen. And so we'll come back to that. So I told you may see some familiar slides. I want to take us a little bit through the history of how it is that melanoma in situ came into existence. And Dr. Margub already told us about the early days and how in the 70s it pretty much didn't really exist as a diagnosis. And a lot of this was pushed forward by Dr. Bernie Ackerman, who was the founding dermpath director at NYU, where I now practice. And a big part of what Dr. Ackerman wanted to achieve in raising awareness around melanoma was the idea of stamping it out as a disease, right? He put forward that editorial article, "Nobody Should Die of Melanoma." And he was a very clever guy, Dr. Ackerman, and one of the studies that he proposed to do was to try and identify the histologic criteria that result in melanoma that is known to have metastasized. In other words, what can we identify about the histology of melanoma that we know is going to be aggressive and recur, and to categorize that. And so he published this paper in 30 melanomas in his cohort that were known to have had recurrence, and these include elements like poor circumscription of the intraepidermal melanocytes, lateral extension of the intraepidermal melanocytes, atypical melanocytes above the basilar layer, pagetoid scatter basically, variation in size and shape of nests, and so on and so on and so on. And the point I want to draw your attention to is that 7 of 9 of these criteria describe intraepidermal melanoma. So these are supposed to be features of invasive recurrent melanoma, but he's describing melanoma entirely in the epidermis for a lot of it. And so the NIH Consensus Conference in 1992 was convened to discuss both thin melanoma, early melanoma, and they included melanoma in situ in that conversation. And what they said about that is that it is a lesion of uncertain natural history, but it can be treated effectively with conservative surgery. And once it's totally removed, melanoma in situ should have no impact on patients' longevity or insurability. You've heard me say that already if you were at the morning session. So even in 1992, the idea of melanoma in situ as being something that really shouldn't affect people's overall survival was well established by experts in the field. So moving forward in time, there's been a lot of work by very clever and brilliant scientists in terms of understanding not just the morphology of melanoma under histology, but actually what's going on at the molecular level within these tumors, even at the earliest stages. And a lot of that work happened before 2015, but I would say that this paper published by Boris Bastian and his group at UCSF was probably one of the most seminal papers and elegant papers really, to look at exactly how the molecular evolution of melanoma happens from benign lesions. And what they did is they took 37 melanomas that had arisen in the context of precursor lesions, whether it was melanoma in situ or a background nevus, and they did laser capture and microdissection of each of those elements. So they took nevus out and sequenced it. They took the intermediate or the in situ melanoma area out and sequenced it. And they did the same for the clearly invasive melanoma, as can be seen on the top left and bottom left diagrams. And they really had two important findings from doing that genetic analysis. They showed firstly that as you move from benign to intermediate to malignant, you actually have an increase in the expression of driver mutations, okay? So in this particular instance, the one they saw most commonly was copy number increase in BRAF, which we know now is an extraordinarily important driver of melanoma in the MAP kinase pathway, responsible for half of acquired nevi, but also melanomas, cutaneous melanomas. And specifically, they saw copy number increases in BRAF V600E. Okay, so that's one important concept: acquisition of more driver mutations as you become malignant. The second finding is on the bottom right, which is that as you move in that same sort of spectrum from benign to intermediate to malignant, you lose important tumor suppressors along the way. And in this case, they demonstrated loss of CDKN2A, which is the 9p21 locus, and that encodes two very important tumor suppressors, P14ARF, but more importantly, P16. And so we know now that those events, acquisition of driver mutations and then subsequent loss of tumor suppressors, is extremely important in melanoma genesis. So the model that's come into play is this sequential acquisition of mutations and loss of important cell cycle checkpoints model. As you move from a single melanocyte in the epidermis spaced 1 to every 10 keratinocytes, I describe it as being kind of like a tiger in a jungle. They're solitary creatures, right? And then they hit a mutation like BRAF, and then now suddenly they can grow in groups, and we call those nests. So they go from being tigers to lions, pack animals. And then what happens is, along the way, you can acquire more mutations, either more drivers, or you can lose important cell cycle regulatory elements. You can maybe pop a TERT promoter mutation or lose P53. That usually happens late in the game. And that's when you move into intermediate to melanoma in situ zone, and then eventually on into invasive and metastatic melanoma. And what I want to point out here from this table is that they've mapped out different important genes that are known to be important in melanoma, both benign, sort of intermediate, and invasive melanoma, metastatic melanoma. So the pathway and the specific genes are kind of on the left side. And I want you to look to specifically where you see MIS and melanoma in situ on this. I'm going to highlight it for you. And so I want you to note that genetically, melanoma in situ is essentially, it shares all the same common features as what would be called atypical nevi or intermediate grade neoplasms. So melanoma in situ genetically is a brother or a sister to something that's like a severely atypical nevus, more so than it is to invasive melanoma. So that's an important concept. This concept has become so ingrained that in the 4th edition update of the WHO Tumors book, and I use this specific table from that book and that edition. It's actually since been updated since 2018. There's a 5th edition out now. But if you screenshot the table from the 5th edition, you can't fit it all on one PowerPoint slide. So I'm sticking to the 4th. And more importantly, there's not a lot that's actually changed in the way that the table is laid out. But the point is WHO has moved away from strictly morphologic classification, so superficial spreading melanoma, nodular melanoma, lentigo maligna melanoma. They've moved away from those morphologic classifications, and they've developed what they call the 9 pathways of melanoma that are laid out here in Roman numerals, moving from left to right. And you can see immediately that as you move from the top of the table, which is the benign variant, down all the way to melanoma or malignant, you have intermediate steps, okay? And you also have the relationship to UV exposure. So on the left, you see at the top it says low UV exposure. High UV is where you see the high chronic sun damage, lentigo maligna melanomas. And then you have low or no UV variants. These are acral melanomas, mucosal melanomas, other weird variants of melanoma that really don't have to do, they're more stochastic in how they come about. And so here in the intermediate or high-grade dysplasia or atypia zone is where they put in situ melanoma. And here they are, all right? So this phase, WHO has said, this is not invasive melanoma, this is in this sort of like high-grade sort of dysplastic or atypia category. So I told you that we're going to talk about the empath or the melanocytic pathology assessment tool and hierarchy for diagnosis. So you may have already heard me talk about this, but I'm just going to cover it briefly again in this session. So the empath DX is a reporting scheme that was put out by several melanocytic experts in 2014 initially. And the idea was to corral pathologists around using common language and common classification for melanocytic neoplasia. Because frankly, you know, when I trained, I was calling things a compound dysplastic nevus with moderate atypia. I went somewhere else, I'm calling it a compound melanocytic nevus with architectural disorder and cytologic atypia, the NIH criteria. I moved to NYU, I call it a compound nevus. I mean, it's like, you know, what's going on here? It's the same lesion, you know? So they proposed this scheme to try and get people to sort of centralize their language in their reporting. And they proposed a 5-class system, classes 1, 2, and 3, essentially equating to mild, moderate, and severe atypia. And then classes 4 and 5 were thinly invasive and thickly invasive melanoma, all right? And then some of the variants they threw in there with the different classes. So for example, you'll see that there are Spitz nevi and Spitz tumor in class 2 and class 3. Blue nevus, you know, that's kind of in your class 1 low risk. And where did melanoma in situ land? Right there in class 3. Again, common theme. So high grade atypia or dysplasia, not yet melanoma. Okay. So they actually tested that. They found that people had very poor inter-reader and intra-reader variability in terms of how they would implement that scheme. And in particular, the class 2, which was the moderately atypical zone, was just a total disaster. Nobody could reproduce class 2 at all. So they revised this classification scheme in 2023. And you can see the author block is a lot bigger. There are some very recognizable names if you know the world of dermatopathology. And people are really trying to get around this empath scheme to make melanocytic reporting a lot more understandable and sort of portable, so to speak. So someone hopefully should be able to take a path report from Texas and have it understood in Seattle or in New York or in Hawaii or in Argentina or in, anywhere. And what they did is they essentially eliminated that class 2. So they went from a 5-class system to a 4-class system, with class 1 being low-grade lesions, leave them alone. Class 2 being high-grade lesions, probably best to cut them out. Class 3 and 4 are the same as what 4 and 5 were before. Melanoma, thin, low risk, invasive melanoma, higher risk, okay? And again, you'll see in this class 2 high grade, they have a lot of, different lesions in here, including Allspitz nevi, cellular blue nevi, and melanoma in situ and lentigo maligna, which interestingly they actually tease out as different entities now in this latest update. So they also provide pathologists very detailed criteria for how you can arrive at the conclusion of what's a low-grade lesion that I can tell someone it's okay to leave it alone versus a class 2 lesion, which is something they should cut out. And I'm not going to bore you with all those details, but they're primarily histomorphologic features at this level of the game, but there can be some molecular data and immunohistochemical data that gets included in there. And then they also provide a distinction between class 2 and class 3 lesions, how it is that you tell something has gone from being atypical but not melanoma to when is it sort of tipped over. And prime in this is also the inclusion of molecular analysis, going from a 1 to 2 hit lesion early on to if you have you've layered on multiple genetic hits on your genome, at that point you've probably crossed into melanoma, and you can see that all on the bottom part of the table. Okay, so for the last few minutes of my portion, the question is, like, why rock the boat? Why change the name? Why does it matter? Why don't we just tell people you have what we call melanoma in situ? It's not really cancer. The thing is, a lot of people still call this malignant melanoma in situ. It's in the diagnosis, right? A lot of these get billed for malignant excisions. That's actually a big, reason why people like that diagnosis, I think. And so, what should we do about these lesions? And so, David Elder and group wanted to look not only just at melanoma in situ, but also even thinly invasive melanomas and try and tease out a subset of these that are so low risk that they essentially pose no risk to patients. You've seen this graph already if you saw my talk from earlier, but essentially there is a subset of melanomas in the SEER database that essentially are in young patients. They're Clark level 2, meaning it's just microinvasive disease, a couple cells in the papillary dermis. There's no dermal mites, and thin, Breslow depth being 0.4 essentially. And these melanomas, if you see the 7-year survival, melanoma-specific survival, it's close to 100%. It's not 100, but it's very close to 100%. And they made the argument on the basis of this and the knowledge already that melanoma in situ has, again, close to 100% survival, that we should just change the terminology at the path level. Let's just dump these into a different category. And what Dr. Elder, who leads a lot of this work, he said this really interesting and thought-provoking quote here, which is that the significance of MIS has been called into question. So this is entirely opposed to what Dr. Ackerman's assertion was, right? He's saying that studies have demonstrated that any presumption that MIS that's left untreated is almost certain to progress and cause the death of the patient is unfounded. Basically, the data just does not support that. And I like this point, even though I didn't highlight it, because severely dysplastic or atypical nevi cannot be reliably distinguished from MMIS, we just can't tell, there's justification to collapse these all into the category of that class 2 under the empath that they've proposed. So what he said in a different article is that these should all be renamed as melanocytic neoplasms of low malignant potential. Melanoma in situ, these subclasses of T1A lesions that are extraordinarily low risk. And admittedly, This is not it's a cumbersome phrase, it's a mouthful, but I'm going to show you some interesting data, and there are ongoing studies looking at what happens when a patient receives a diagnosis like this, rather than being told that they have melanoma in situ even, all right? So last year, there was a group based out of Australia that published this paper in the British Journal of Dermatology, estimating the financial impact of melanoma in situ and thinly invasive melanomas and the overdiagnosis that they attributed to those entities, okay? And so specifically for melanoma in situ, like Dr. Magrub estimated or quoted that paper that they estimated upwards of 80 to 90% of MISs were overdiagnosed. They said 67 to 70% of their MIS were overdiagnosed in 2017. And this resulted in somewhere to the tune of $17 to $18.5 million worth of unnecessary treatment. So there's a very real financial impact that happens to the health system. Okay. What about the psychosocial well-being, which is probably more important to our individual patients, all right? So this study also came out last year out of this group, and this is kind of a meta-analysis of studies looking at psychosocial impact and qualitative data in melanoma patients. And they were able, of the 20 some odd studies that they included in their analysis, they found only 2 that specifically called out melanoma in situ as its own category, okay? And what they found is that when it comes to psychosocial stress and distress, that there's actually no difference between receiving a melanoma diagnosis, a thick melanoma diagnosis, a thin melanoma diagnosis, or an MIS diagnosis for patients. It caused a statistically insignificant difference in stress in these patients. So it's very real. It matters for them. Even, we think to ourselves it's just MIS, it's fine, but it can have a big impact. So they published the results of their own little follow-up, recognizing that there just weren't many of these lesions, or these studies rather specifically looking at MIS. They did their own qualitative interview, and here what I knocked out is probably too hard for you to read, but I'll read it. It's a comment, representative comment from one of the patients. They said, so previously it had never dawned on me, but now it's definitely different. I do get a little bit anxious, and once it was out, meaning it was removed and sent for biopsy, I was extremely anxious, just waiting for the results. So I practice in New York City. I'm in Midtown Manhattan. Anxiety is through the roof. People, clinicians are calling. They sent the biopsy last night. They're calling me at 6:30 in the morning. Do you have the result? What is it? I mean, it's amped up the level of anxiety around melanoma, and I think we could do a real service to our patients if we take the hard step of dialing back some of this rhetoric, including war on melanoma and these other things, including all of this in that mess. I think has maybe done, it's my own opinion, but it's maybe done a little bit more harm than good on balance. So I want to bring it back to my patient, because I was taking a page out of the book of Margub, and she was needle phobic. There's no way she wanted surgery. All of her the thick melanomas that she had that were excised, none of them had lymph node involvement, which to me was amazing. Probably says something about the indolent nature of what she developed, having background protective melanin in her skin and still having XP, and probably being covered most of her life on the spots that she was still developing these melanomas. But in the end, I managed to convince her to do something about this. I don't know if it was good or bad, but in the end, I said, it's pretty big if it were me. And she said at the outset, she said, if I do this horrible cream that you keep telling me about, can I stop wearing the makeup cover-up? She worked at I won't say where, but she worked at a very public place. And I said, yeah, I think there's a really good chance that if you do this and you stick to the cream and you do it for 3 months and you get the response, I have a good feeling about what can happen. And it was the first and only time I ever saw her smile was after the treatment. She sent lots of pictures of her forehead looking like a grenade had gone off. And in the end, I think she was really, really pleased. So yeah, I'm a believer in vitamin I. Anyway, we'll put it that way. But thanks for your attention.
All right, so now we have Laura Ferris, who's going to bring us up to speed on technology and its impact on this field of melanoma in situ. Thank you, Laura.
See. Almost pulled up. I saw it briefly. There we go. Okay. So I'm going to talk, I'm a little bit going to lump in early melanoma and melanoma in situ here, but there's been such an explosion of AI and technologies to help us diagnose melanoma earlier or help us with making decisions about what lesions to biopsy. So I wanted to focus a little bit on what impact might this have on the diagnosis rate of things like melanoma in situ, and also how is the way that we've gone about thinking about validating these tools and examining them and even training them being impacted by melanoma in situ and thin melanoma. So, we have certainly, I think most of us have gone through our career with certain assumptions that, we've talked about this, that we've always assumed that melanoma can be detected early and maybe even better with technologies, and that was, something that sort of drove me earlier in my career, and that making the assumption that melanoma can progress from detectable but curable to a fatal stage if we don't actually find it and remove it. And so, we have reached the conclusion without a lot of data that anything we can do to increase early detection will result in reduced melanoma mortality, morbidity, and treatment costs. And my two colleagues have probably convinced you now that that isn't exactly the case, but so now I'm going to move on and talk a little bit about technologies. So when we're making decisions about which pigmented lesions to biopsy, it's still hard, and it's still hard for me after 23 years in practice. So there are, two lesions here. One's a melanoma, one is not. They look awfully similar to the naked eye. With dermoscopy, we'd probably get some more clues. But again, realize dermoscopy is something that requires training. And if we think about, for example, where do most patients present? It's oftentimes to primary care physicians who do not have access to or training to use dermoscopy. So oftentimes you're just left with looking at this lesion. Also, both of the lesions on the bottom are melanomas. One of them, we do not need any tools to help us with. The other one, maybe one of the ones that we would classify now as being overdiagnosed based on its small size and regular appearance. But these were both melanomas, so this can be hard, again, to make those decisions. So how good are we at making biopsy decisions? We can look at this through reader studies, which would suggest that depending on, I would say, the complexity of the data set, our sensitivity may be as low as 63% or as high as 97%. And Kelly Nelson did this review a few years ago looking at the number needed to biopsy to find one melanoma, and the mean was about 13 for US dermatology practitioners. If you looked at people who were, world-renowned dermoscopists, it was oftentimes 2 or 2.5 lesions per melanoma, and if you looked at people who were not using dermoscopy, and particularly in the primary care setting, it could be as high as 30. Okay, so this kind of brings up the idea then, all right, well, what if we can combine both expertise and advanced technologies? And this was a paper that came out in 21, and I was asked to write an editorial on it, and this has really made me think a lot about, how are we, with expertise, with technologies, and with even our greatest experts, are we able to impact melanoma mortality basically through early detection? And so this was a study, and if you look at the authors here, this is like a who's who in Australia of all the people who have written the texts on screening and on dermoscopy. So this is a very accomplished group of physicians. And so they followed 593 high-risk patients for about 3 years. They had a skin check every 6 months with total body photography, with dermoscopy, and not just, dermoscopy of suspicious lesions, but serial digital dermatoscopic imaging for most of the lesions that ended up being biopsied. There were 171 melanomas diagnosed in this group in 3 years. I mean, that's just really, phenomenal when you think about it. Most of these were actually done not just with the expertise of the physician with their dermatoscope, but actually with the aid of tools, including serial imaging, serial digital dermoscopy, identifying very subtle changes, and 68% of those melanomas were melanoma in situ. So, we know that about half of all melanomas that we biopsy as dermatologists come back as melanoma in situ, but, by augmenting this with technology, that went up to 68%. So, my first thought in writing this editorial was, gosh, are we really driving over diagnosis by using these tools? But the second thing that when I was going through all the data and looking at it, I thought, all right, well, maybe we are, but, are we saving lives? I mean, these are high-risk patients, so maybe we can tolerate that if we're preventing them from having thick melanomas. And what was kind of staggering to me was that with this level of intense scrutiny and use of technology, there were still 10 melanomas that were 0.8 to 1 millimeter. That was 5.8% of them. And there were 7 that were thicker than a millimeter. So this has really stuck with me, that I don't know that we can use screening and technology to really screen our way out of finding thicker melanoma, or out of the thicker melanomas. Okay. So I'm going to move on and talk a little bit more about some of the technologies that are out there. And also, I just want to think about it in this session about, in the framework of what we're talking about, and, thin melanoma in particular. So I think, one, as we look at technologies, we ought to think about which lesions do we want to identify. So, do we want tools? I think we would probably say yes, we want tools that are able to identify invasive melanoma. I think that the question is, how important is it to have a high sensitivity for melanoma in situ? And then what about things like severely dysplastic nevi? I think most of us in this room, and looking at the data over time, would say, we don't really want technologies that do that. However, when you look at how the FDA reviews tools, they actually ask companies to consider nevi with, severely dysplastic nevi, whatever terminology you like to use, to lump those in as positive cases, and to have tools that will identify all severely dysplastic nevi. So you can imagine that is going to drive down specificity. If you are trying to find every dysplastic nevus, you're also going to find every melanoma in situ, as well as every invasive melanoma. And then I think, non-melanoma skin cancers are another thing to consider. Do we need tools that are going to be sensitive for this? Because if so, if the broader of the lesions we are trying to identify, it's going to also mean that it's going to lower specificity. Okay, it's also going to be important to think about who is using these. So something in the hands of a dermatologist is probably going to be different than something that maybe sits in a pharmacy with a pharmacy technician using it as initial screening device. And this is true, or a primary care physician, for example. And of course, patient-facing tools, we're probably going to need to have different sensitivities and specificities for. Okay, and then why are we doing this? So I think when I started all of this, I thought, well, clearly we're doing this to find more melanomas. But now I'm really starting to think we should be doing this to see if we can do fewer biopsies. And then the other thing is, we are doing these on patients who are, of course, awake and participating and making shared decision-making, with us. And so how do our patients want us to use these? And I think that this is something we need to think about, because if you ask a patient, they will tell you they want this tool to find every potential melanoma. They're probably less concerned with us using it to do fewer biopsies. So we currently have, I'd say 3 tools that are available to us right now at the lesion level. This is Nevisense on the left. This is the FDA-approved tool. This is this is FDA-approved for use by dermatologists. We have DermaSensor, which is FDA-cleared. and this is for use in patients 40 and older by primary care physicians. And then we have this DermTech pigmented lesion assay, which is actually still available, and this is not regulated by the FDA at all. This is just performed in a CLIA-certified lab. So this is sort of the registrational study for this electrical impedance spectroscopy device, Nevisense. Has a very high sensitivity for melanoma, 96.6%, specificity of 34%. You can see positive and negative predictive values, and then sensitivity for keratinocyte carcinomas of 100%. So, this is kind of an older study. This is, though, what we can see. We could see it does give us additional data. It is a score. The lower the score, the more likely the lesion is benign. And then for, looking at T3, T4 melanomas, these had much higher scores than, for example, melanomas in situ. So, in using these tools, if you're just getting a high-risk, low-risk answer, you're going to end up bringing in all the dysplastic nevi and, in situ melanomas as well. But tools like this that at least give a score, there is some ability to, consider that something that is a score of 10 is probably an invasive melanoma, whereas, potentially something, as you can see, severely dysplastic nevi and melanoma in situ have very similar scores. It's really a matter of setting the threshold of how concerned to be. This was a study that was done using this as an adjunct to telemedicine. So, and this was done at NYU. They basically invited a bunch of patients, I think 375, who had a lesion of concern, said come in and, Arm A is we're going to look at the patient and we're going to say, should we do a biopsy and then look at the skin cancers that were that came out of this, that were identified. And then Arm B was each patient went through each arm. In Arm B, they just took images and then had a teledermatologist read them, and they made the same biopsy recommendations. They made their biopsy recommendations. And then in Arm C, they had the teledermoscopist get the EIS score from Nevisense. So what can we see happened here? We can see with each level of kind of separation and bringing in technology, and specifically adding Nevisense to it, you went from a biopsy recommendation of 36 from face-to-face evaluation, 43 in telemed, up to 74 biopsies being performed. Now, there was one additional melanoma that was identified in the face-to-face visit and picked up by Nevisense, but was missed in the telemed. And so, there were only 2 melanomas in this. This is the one that was identified by all groups, so probably something that is a pretty obvious. This was an invasive melanoma. This is one melanoma in situ that was identified using technology. So, again, realizing this increased the sensitivity, but at the cost of doubling the number of skin biopsies that were done. This is DermaSensor. This is this newly FDA-cleared device. It uses elastic scattering spectroscopy. This is the data from their registrational study, and so this was tested in over 1,000 patients. And if we kind of focus on the melanocytic lesions, so there were, if you look at the initial tables, it'll say 48 melanomas, but when you go into the paper, it's actually 48 melanocytic high-risk lesions. What does that mean? 19 of these were severely dysplastic nevi, 29 of those were melanoma. And you can see here what they did was they looked at PCPs, decision to biopsy. All of them were ultimately biopsy, but they looked at PCP sensitivity for all skin cancers and for melanoma versus device sensitivity. So you can see the PCP sensitivity to all skin cancers was 83% in this cohort. The device sensitivity was higher, was 95%. However, when we look at specificity, we can see that the specificity of PCPs was about 54% versus it was 20% for the device. Now, the sensitivity for melanoma was 90%. However, I would argue that we actually, by trying to be overly conservative and put dysplastic nevi in there, you actually sort of raise the denominator of melanocytic lesions. And so when you look at the missed melanomas here, it was actually, there are actually 3 missed, and I think it's 3 missed invasive melanomas, 1 in situ, and 1 severely dysplastic nevus. So you're actually sort of increasing that diameter, and the lesions that were actually missed were primarily like true melanomas. So there's actually some harm in trying to be overly inclusive in those numbers. So So I just will put that out there. And then this was a study that we did when I was at the University of Pittsburgh. We got this device and we just said, what if we use this to pre-screen patients who came in with a lesion of concern looking to see a dermatologist? And so in our cohort, we had 3 true melanomas. We had 9 basal cells, 10 squamous cell carcinomas. And then we compared what did the dermatologist decide to do, and if it was biopsy, what did the pathology show, to what did the device say to do. So interestingly, what we found was that we reassured or monitored 33% of patients, whereas the device only sort of gave the advice to monitor 8%. Now, again, this is using a very conservative threshold of any degree of atypia being, driving biopsy. What we can see is if we are comfortable with, potentially missing some things like non-melanoma skin cancers, we can maintain a relatively good sensitivity while improving that specificity pretty significantly. So, however, this is going to come, that sensitivity does come at the cost of specificity. And again, how is that positive result, which pops up on a screen to the patient, going to impact decision making? I think it's going to be hard to override that and say, I know that it's a positive result, but it's a low score. Let's continue to watch that. I think, it'll be interesting to see how this pans out in real world use. And if patients will use this as a reason to forego referral or biopsy. Okay, this is the DermTech pigment and lesion assay. This just basically is a piece of tape that looks for the presence of one or both genes, which one is a long non-coding link, which is a non-coding RNA, PRAME, which we know is an antigen that's expressed in melanoma. We also know in many other melanocytic types of lesions as well. And so this piece of tape is put over a lesion. It's sent out to the lab. They say either you have, neither gene is present, that's a negative test. Either one or both, link or PRAME, are present, that's considered a positive test. And in studies, this had a sensitivity of 91% and 70% specificity. I don't know. Should I, what's it? So are we okay to should I just keep going? Keep going, okay. So that's how this looks. So kind of the next part of what I want to talk about is, how does real world performance mirror, clinical trials? So this I thought was interesting. This was a study that was not funded by the company. This was actually Forefront Dermatology. One of the private equity groups, they said, well, we've sent out 893 of these tests. Sometimes, in some patients we've got follow-up, but how did our results compare to the study? And so what they did was if we looked at a positive test was having one or both genes, a negative test was having neither. They found that in their sort of group practice, sensitivity was 92%, which is pretty similar to what's been reported before, and their specificity was 79.5%, which also was kind of similar to what was presented before. So I thought that was interesting. The other real-world study that I thought was interesting here was this is looking at another group in California, and they looked, Brooke Barua was the author, but it was looking across multiple groups that were using the test. So they looked at over 3,400 uses of the test, and 324 of those were positive. So if we look at, and then you can see here the number of benign lesions and melanomas that were identified. So I'm also trying to look at the cost here. And so I'm going to use, $760 as the cost of running the test versus $175 for doing a biopsy just with H&E. So you can see with over 3,400 tests, 316 of the 324 positives were actually biopsied. There were 47 lesions that were melanoma in situ, so we can see the majority of them were benign lesions. 47 were melanoma in situ, 11 were T1As, and 1 was a T2A. So, what does this mean? Using this technology, you had to run over 3,400 tests, to find these 59 melanomas. So number needed to treat to find a melanoma, 58, cost $44,000. If you said, all right, well, what about what's the cost just to find the invasive melanomas. That is, number needed to test was 285 to find one of those at a cost of $216,000. And then to find that one T2 melanoma, which is probably the one that has the greatest, potential to cause death, is $2.6 million, are testing 3,418 lesions. So I think it's important to think about these things. Okay, so I have now kind of tried to think a little bit differently about, how I use these tests and how I talk to other people about using these tests. And instead of just thinking about sensitivity and specificity and positive and negative predictive value, I like thinking about this in terms of likelihood ratios, because when you're thinking in terms of likelihood ratios, that means that your pre-test odds of something being melanoma come into play are important. So a likelihood ratio positive is when you're using something as a rule-in test. So if I said with a positive test, how much more likely is it that this lesion is melanoma? So, this is, you can see the math of, the sensitivity over 1 minus specificity. And if you use a likelihood ratio negative, it's, thinking about this as using it as a rule-out test. So if this test is negative, how much less likely is it that this is melanoma? So this is, you can see the sensitivity and specificity and how they go into that. So if I just take from these different devices or tests, if I use the sensitivity and publish specificity and calculate a likelihood ratio of positive and negative for each device or tool, I think you can see that one, they're probably better rule-out tests than rule-in tests, right? And then you really want to think about your post-test odds. So after I get that result back, what are the odds now that this is a melanoma? And that's going to depend on your pre-test odds and your likelihood ratio. So, one, I think before we use these tests, we should think, what is, in my mind, is the likelihood or probability that this is going to be a melanoma? That's going to depend on, it's going to be different for me than it will be for a primary care physician. And so I think that's why it's important to think about who's using these. And then if you said, all right, there's a 1% chance I'm going to do this test, if you do it and you get a positive result, and your likelihood ratio positive is now 1.5, does a 1.5% odds sway you any more than a 1% odds? Now, where this could be useful is what if you said, I think the odds that this is melanoma is about 20%, right? So, but maybe I don't want to have to do a biopsy in this patient. If you get a negative test, and this has a likelihood ratio negative 0.1, a 2% odds in the right patient, in the right setting, may sway you not to do a biopsy. So, I think it's important to really think about this before we're doing these and not use tools to find melanomas that, we would have never biopsied before, but to think about them more as ways to de-escalate biopsy. And, this is sort of looking at, I did participate in some of these DermTech studies. So, just looking across the results, this first study was done by me and Padram Garami, who's also a dermatologist and dermatopathologist. He's a very world-renowned pigmented lesions expert. So, we were running high-risk specialized clinics. We evaluated this in 200 patients in whom we had already made a decision to do a biopsy. And overall, 27% of our tests were positive, and the percent of our positive tests that were melanoma was 35%. So I look at this as this result would have informed me, did I have to biopsy it? Could I have avoided biopsy in some of these patients? Sensitivity in our lesions was a little under 90%. In another registry study done in more of a primary, a community dermatology setting, you can see that they did over 3,400 tests. Only 10% of those were positive, and of those positives, 19% were melanoma. And then in a second registry, pretty similar numbers. There were two slightly different versions of that test. But I suspect that in that real-world setting, they were using this a little bit more in the, maybe I could watch this, but I'll just run a test and see if I could biopsy. So I think they were using this more to say, should I do the biopsy versus should I not? And you can see that impacts test rate positivity. This is another kind of interesting tool. This is one that is being used in the National Health Service right now. And so it is basically using AI reading dermatoscopic images to say, can we triage patients? Can we triage lesions that are referred? Now, what's interesting is that you can see that what it does is it first says, is this a melanoma? Yes, you're triaged. And it goes down the list to least severe things, down to atypical nevi or benign. However, the GP referral threshold is set at anything that triggers as being an atypical nevus or beyond. So, you know, again, while this is actually being deployed, I think it's going to be really interesting to see how much it is able to avoid referrals. And this is looking at, I'll just show you quickly, data from one of their studies where they looked at use across a couple different centers, and you can see that when every lesion was actually, you know, evaluated by a dermatologist, that the sensitivity for melanoma or all skin cancer was high, and the specificity was not bad as well. When they did look at this study and they said, you know, let me look in these two settings on the right on both ones are lesions that were assessed by the tool. On the left were lesions where they didn't use the tool, they just went through the standard referral pathway. This tool was able to actually say you don't discharge patients in 25 to 40%, depending on which group you used. And then when they did go back and review those cases, none of them were skin cancer. In the ones that were reviewed, there were more skin cancers, so higher positive predictive value. So potentially that does help, you know, with sort of triaging referrals. Whereas without having any sort of triage, the majority of the lesions, there were much lower prevalence of skin cancer and melanoma. So what I want to kind of end on is, you know, these are interesting technologies for looking at single lesions, but, you know, what about looking at whole body imaging? And, you know, as we're talking about what are lesions that are indolent, and we saw examples of lesions that change very, very slowly, can we use AI to basically help us to quantify change? Because we know that, you know, change is the definition of growth, which is the definition of cancer. So, you know, many of us have for years used these serial images. Now there are these tools that can actually, you know, help us to not just, you know, map patients, but also have technology that finds lesions that are new and changing. We did have one randomized controlled trial that interestingly did not show what we thought it would show. So what they did was there was a group who had serial imaging with the vector system, which was the 3D total body photography system, and then another group that just had routine exams by physicians. And so what we can see here is sort of the opposite of what they thought they would see, that there were actually you know, more melanomas identified without technology, similar number of melanomas in situ, more keratinocyte carcinomas identified, but also just way more skin biopsies of benign lesions in the intervention group as well. So this was, I think, partly a unfortunate aspect of the study design, that you had more benign lesions and fewer melanomas, but there was more scrutiny. There's more scrutiny applied in the intervention arm, and it was done during COVID. So I think we're going to I'm not going to let that be the jury is out on using 3D photography. This is another study that I thought was interesting, which used, you know, specialized imaging in centers in Germany. And so they looked at patients who had imaging consultation visits and just routine outpatient, a dermatologist with a dermatoscope is the routine care. Imaging consultation is you also have digital dermoscopy and 3D total body photography. They kind of saw the opposite with imaging consultation. They found that there were more melanomas, and in particular more invasive melanomas when you use things like 3D photography to help you identify changing lesions, and a similar number of in situ melanomas, but far fewer biopsies of benign nevi, and that the number needed to excise went down dramatically, like oftentimes 10 or more fold by using imaging. So I'm hopeful that this is going to be a way to help us find the important melanomas, which are the invasive ones, and hopefully limit the number of benign nevi. Okay. So, I think this could also help us as dermatologists. Our time is an important resource. We spend a lot of time physically examining the patient to just, weed out the multiple benign moles to see if we can figure out which ones we need to focus on. So, looking at these different technologies, this is one that compared 3D and 2D imaging. Well, you could, the black dots are melanoma, and that's sort of like the highlight of the results here. What I thought was really interesting is these are all the benign lesions. So maybe instead of thinking about these as technologies to pluck out all of the melanomas, what if we say, many of these tools are really great at saying what we don't need to worry about. So I am now trying to think about this as, can I just figure out pluck out the benign ones, and then I can spend my time on the fewer suspicious ones. This was another study that was done actually with Memorial Sloan Kettering. You can see these are all patients who had, imaging with the vector system, which does give an AI readout and ranks lesions from most to least suspicious. These are all the patients who had at least one melanoma, which is the red lesion. And if you look at the severity score, you could see that the vast majority of them are the patient's most suspicious lesions. So what if you said, I don't even have to, look at below this threshold or below this one? It turns out that 28% of melanomas were the highest scoring lesion. Over half of them were in the top 99 percentile, and 79% were in the top 95th percentile. So even if we could just examine 95% fewer lesions, we could probably really, have an impact on access. Okay, so this is, something that I thought was interesting is, we're one of the only specialties that finds cancer by having a physician look at every inch of the patient. So, in breast cancer, we don't examine patients' breasts. We send them to a place where they can get a mammogram, a radiologist looks at the film, and then they come face to face with a clinician when there's a lesion of concern. Prostate cancer, same thing. We order a blood test. You only come face to face with the urologist when you need a biopsy. And so potentially, maybe with imaging, we could do this as well. I'm going to skip over my cost stuff, but one of the reasons, basically, that we did this study in Pittsburgh, one of the reasons to avoid a lot of face-to-face visit is that we spend a lot of money doing low-value care, doing things like freezing seborrheic keratoses or, even actinic keratoses, and a lot of the cost of melanoma diagnosis is actually caught up in the cost of sort of treating the other incidental things that the patient comes in to see us for. So there are a couple companies that are looking at this. This is one called SkinBit, where they say, we could have the patient, we could be in a mall, the patient would go in, they would get their full body imaging, that could be remotely reviewed, and then we'd only have urgent referrals or referrals for lesions that are truly of concern to dermatologists that this could help with access. This is another one, just I put in a few different companies, Lumo Scanner. Essentially, that does the same thing and then even can look up, it so closely as to get dermoscopy-like images, which could then go through things like, 7-point checklists. And so we could apply AI to having, the most suspicious lesions identified too. And then this is one of my favorite ones, which is this robot that essentially could go up and down the patient, photograph every lesion, get dermatoscopic images that were actually in this study in JAMA Derm so high quality that the dermatologists who read one lesion that was the same lesion acquired by this device and another one and by a traditional contact dermatoscope, they couldn't, they couldn't tell the difference. So this would actually be a way to get sort of that full body imaging. So I think that there's a lot of kind of interesting ways that we can think about technology. I think one of the important things that we're gonna need to think about though is what is the endpoint that we are looking for? And how, what is the study design? So are we looking for all sensitivity to for all melanomas or for all skin cancers? Are we looking at sensitivity similar to a dermatologist? Is our endpoint, treatment cost? Is it detection rate? Is it melanoma-specific survival? And I think we don't really have the answer for all of these yet. So, in conclusion, I think, we want to make sure that when we're using technologies that we're not just thinking about detection. I think we want to be making sure that we are being very aware to minimize overdiagnosis, that we are focusing on identifying potentially lethal melanomas, that we are using these to identify stable indolent lesions that, regardless of what they might show histologically, probably don't need to be removed. Somebody who practices in a very rural state, I think we need to make sure that we are not doing this at the cost of access. So the more time that we spend with very intricate exams and lots of tools at the bedside is just going to hurt access. And and then I think we ought to think about, how we evaluate, train, and regulate these tools might impact diagnosis as well, particularly including severely dysplastic nevi in both training and validation sets. So thank you very much. Okay.
All right, so we have about 20 minutes for questions. So if anybody has questions that they want to ask, come on up to the mic. And I think we're all kind of gravitating towards the same. I 100% agree that the benign, weeding out the benign is huge. And a lot of the technology that we are doing is doing kind of the same. And I think that it's going to require us to upskill what we do for those select few lesions that remain after. And whatever, ancillary technology and our upskilling together will help, weed out the problem even further.
Yeah, I want to give credit to, so we had a session on this at a meeting, and Henson Tsao got up and he said, the problem, and this is like really just giving me so much clarity, he said, the problem we have with melanoma detection and screening is it's a signal to noise problem. So, right, like if you think about breast cancer, like patients have two breasts, and there are not two breasts that are full of 150 masses and only one of them is the cancer, right? So, like when he said that, I was like, you're right, this is the problem. So let's use technology to help us with the signal to noise.
Michael.
Michael White, live in flyover country out in the Midwest. My nearest neighbor is a quarter-mile away. I live in true rural area. So I comment and a question. I like a lot of the ideas of using technology, particularly when I put it in the hands of NPs and PAs, and I'm one of those guys that works with them, because where I live, a lot of people, if they didn't have an NP or a PA, there would be no health care at all. However, I do live in the country, and the devices and so forth, as being used right now, are not going to be deployed to the country. They're going to be deployed in the big cities where they can do a lot of benefit. But people need to stop talking about rural medicine, because the things that they have there are not going to work in a rural setting. There is a rural care initiative that we're working on right now that may make a difference, putting dermoscopy and tools in the hands of the rural nurse practitioners and PAs. That has promise. The question is, I found the genetic stuff really interesting. So if I follow you correctly, the gain of a BRAF mutation is important, followed by the loss of certain other tumor suppressors. How is that happening? If that's ultraviolet, then I marry that to the distribution of where melanomas happen, which doesn't match the high ultraviolet exposure distribution on the body, and I'm going, wait a minute. It suggests to me that there may be two populations, where one population where these mutations take place are in fact the ultraviolet exposed, and those are the lentigo maligna melanoma in situ kind of tumors, and we may be able to separate out more by looking at the mutations and saying, okay, because of this mutation, this is not likely to be invasive, not likely to progress, and you don't have to do anything.
Yeah, that's a really excellent point. And I think in showing the WHO table, I didn't harp a lot on the very bottom of it that was color-coded, but each of the 9 pathways that they lay out have characteristic mutations that are the beginning and endpoints of those pathways. So, for example, common acquired nevi, which their malignant end of that is what we would normally call a superficial spreading melanoma. Most of those are driven by acquired BRAF V600E mutations. Mucosal melanomas and acral melanomas, They're common drivers, not the most common, but a common driver is KIT mutation, for example, not acquired by UV, right? Not UV driven in either a mucosal site or in the vast majority of true acral lesions, which are palmoplantar or nail. Desmoplastic melanomas oftentimes have knockout of NF1. That's kind of like the seminal driver, and then they lose P53 as like a second event that happens in those, which is interesting because you see desmoplastic melanomas more commonly in patients who have germline NF mutation. And so I think your point is an excellent one. A lot of this work has been hashed out, and so even the morphology of certain lesions, including, I'm thinking Spitz lesions in particular, have so like ALK-driven Spitz nevi and or Spitz melanocytomas, which is the new terminology for an atypical Spitz tumor, those have a particular morphology as opposed to HRAS-driven Spitz nevi, which tend to be the desmoplastic Spitz variants. N-track drivers have a particular morphology. I think I think we're developing the story. It's more complicated than I'm making it sound, but I think that there are characteristic appearances and morphologies of different driver or melanocytic nevi or proliferations that have particular drivers. There's kind of a correlation there. And I think your point is excellent that some of them being UV related, some of them not. Clearly, the lentigo maligna type, that type of melanoma in situ, just has a very different course than what you would see on the chest of a young woman who's newly pregnant, for example, with a changing lesion.
Thank you.
Yes.
Hi, thank you. These were all spectacular talks. I want to go back to the beginning to Dr. Margoub, to your lecture, and the topic of monitoring these lentigo maligna or superficial spreading melanomas. And doing that over years, I'm wondering, when you do get to that case where a lesion develops a small invasive component, how are you managing this excision process at that point? Then do you take out the entire melanoma, or do you just take margins out around that small invasive portion? And how are you navigating that with your teams?
So, excellent. A lot of it depends actually on what the size of the lesion is, right? So a smaller lesion that can easily be removed in its entirety, including the invasive component, we do that. For the larger ones, and for just as an example, I have a patient that I just saw last week who has lentigo maligna we've been following for quite a long time, but it's across her entire upper lip onto the mucosal aspect. It goes onto the gingiva, and so it's completely a non-resectable disease, and she developed just an invasive component in the middle. In the end, on that case, we just remove the invasive component. And then are just monitoring the remainder. So there are times where it's just not an operable disease, but obviously there's an in-between as well. So there are individuals where we won't chase margins, for sure, all right? So we will remove the invasive component, and if the margins are positive in situ disease, we're still okay with that. We'll offer imiquimod in that scenario. To maybe clean up the remainder. Most patients actually elect for that. So I think it's a case-by-case basis. How easy is it to remove? Can you remove it at all? Is imiquimod come into the play that can help? And active surveillance, in some cases, even after removal of invasive, the patients decide not to have anything else done. We just then continue to monitor the in situ component. So yeah, I think it's case-by-case, but excellent question.
Thank you for all three excellent talks. Just on the topic of lentigo maligna, two questions, if I may. I was wondering if any of the speakers have any experience with other formulations of imiquimod, such as 3.5% or other strengths than the classical 5%. That's one. And the other one is, I suppose it's quite tricky, and you've presented this very eloquently, to say what, when a lentigo maligna progresses to lentigo maligna melanoma, or when it gets upstaged, if initially it was a lentigo maligna melanoma that was missed. Are there any practical tips or pearls that we can take going forward, perhaps in how we conduct our research studies, if we want to look at how lentigo maligna progresses into lentigo maligna melanoma going forward?
So on the first question, so 3.5% versus 5%, I'm not aware of any studies on with 3.5%. So I don't think that all of the data was driven by the whatever's out there is by 5% imiquimod. There are different regimens. I mean, one is use it every day for 3 months, but there are variants of that. But I'm not aware. So I don't. It's an unknown. Will 3.5% work? On the second front, if I understand correctly, is that is to understand the biology better of lentigo maligna. Yeah, I mean, I'd be curious to see what Laura and Atta have to say to that. In my experience, it's about, I mean, again, remember this is spanning a long 35 years. I would say I have a handful of patients that go on to develop an invasive disease, and most of the time, if not all of the times, it's detected by dermoscopic changes that are focal within the lesion. So it's not the entire lesion that changes, it's a focus within, and the common features are going to be shiny white structures, vessels, or blue color, which are all features of invasive disease. In all of the cases, nobody has died yet, meaning they haven't developed metastatic disease and succumbed to it. That's not to say that I haven't seen patients that have developed that, as patients referred to me with lentigo maligna. But in my hands, that has not occurred. But the true biology, I think that's part of what we are after. And Atta, I know that there was some issue of one paper that said that if you have just lentiginous spread without nesting, that has a better long-term outcome than if you had nesting.
Yes.
And so there may be clues, but maybe Atta, you could address to that.
I'll try my best. I think it's another one of these questions of, okay, so let me take a step back real quick and draw from the Spitz sort of literature and experience. So true Spitz melanomas in children are extraordinarily rare, right? And if you have a Spitz lesion in an adult, meaning it has a molecularly defined Spitz driver, you also tend to have a much more indolent course, even if it meets criteria for melanoma, than if you had a canonical adult type acquired like BRAF mutation or something else. And so I suspect that whatever driver mutations or collection of weak sort of proliferative indices are present in these lentiginous proliferations, if you add something to tip over some subpopulation of those cells to develop invasion, the fact that your baseline driver is still some like weak growth impulse leads to this very banal and sort of indolent course, as opposed to these pleomorphic melanomas that you get that have some catastrophic genome destruction and TP53 loss and nodular melanoma, all these other things. I suspect it's just the protoplasm to begin with is weak, so to speak. It's not aggressive. And so I think that's probably accounting for that biology.
And Laura, do you think that we could one day have a in vivo test to look for those, for gene expression? I mean, we know we have DermTech, but going a little bit even further than DermTech.
Yeah, I think like what we have now is not sufficient to do that. But yes, to me, like that makes sense. Like hopefully, we can move to a more like genomic classification of melanoma, right? Like right now we're, everything is like based on visual appearance, right? What does it look like to the naked eye? What does it look like to the under the dermatoscope? What does it look like to the pathologist? And then, if we could really go to like classifying these genetically, it's almost like how, we've done this with some of the epidermal